The name of this patient has been changed for this project. I did not have the opportunity, unfortunately, to work with any neuro patients this semester. I saw this patient on the Masonic Integrated Clinical Experience from last semester, and this patient is different than the one that I used for the template. Jill is a 72-year-old female, status post right basal ganglia hemorrhagic stroke. She lives in a single-level house with her husband, who is willing and able to assist her 24/7. She has 4 stairs to enter with a right railing. Her prior level of function was that she was independent with all activities and did not require an assistive device. And her past medical history was significant for hypertension. She presented with mild expressive aphasia, decreased endurance, and decreased strength on the left and impaired balance. She required an AFO on her left foot due to weakness and drop foot. Jill's goal is to return home and to continue going on walks with her husband around the neighborhood. The topic that this video will be focusing on is the use of kinesiotaping during stroke rehab. This intervention will benefit the client during therapy sessions to strengthen her lower leg muscles, and maybe she wouldn't require the AFO anymore. According to Kosoglu et al., kinesiotaping the tibialis anterior had significant effects on motor recovery of the lower extremity, spasticity, and ambulation capacity. It is recommended to be an adjunct in conventional rehab programs similar to FES and AFOs. Strengthening the lower extremity muscles would allow Jill to return to her prior level of function and help her return to her hobby of walking around the neighborhood with her husband. Not only will kinesiotaping help strengthen her lower extremity, but research has shown that kinesiotaping can improve her balance as well as proprioception. Yazici et al. Concluded that kinesiotape worked with some balance activities because it ensured proper foot positioning, but similar to Kosoglu et al., kinesiotape should not be used in isolation, but in conjunction with other neuro rehab methods. Additionally, Young-Han Park found that taping to stimulate proprioception showed statistically significant differences, and the proprioceptive and sensory input could decrease a stroke patient's gait deviations. Even though, in theory, kinesiotaping seems like a great intervention for improving strength and balance post-stroke, there are some barriers to implementation. There is not too much research on using kinesiotaping with stroke rehab and the lower extremity. Additionally, to kinesiotape a patient, you have to get a certification. According to Kinesio University and Kinesiotaping Association International, a certification entails attending multiple classes, paying for and then passing an exam, and the exam costs $99, which could deter some people. You also have to get recertified every 3 years, so there is a time component associated with the certification. Although kinesiotaping has mostly been used in the outpatient orthopedics world, it can be a great intervention option for the neuropopulation. However, some neurotherapists might not feel that all the barriers to implementation are worth it. My clinical judgment regarding using kinesiotape with Jill is that it would be beneficial to try it. She is doing well, ambulating with contact guard assist and contact guard assist on the stairs. The kinesiotaping can enhance the gains that were already made with conventional therapy and help her optimize her function.